to hear from Dr. Nittaya Phanuphak. She is the Executive Director, Institute of HIV Research and Innovation. To talk about key population-led health services model, let's hear from Dr. Nittaya.
Thank you very much, Dr. Kate, and good morning, everyone. It's really great to be here and also to learn about the network and all those wonderful activities that you have done so far. So let me share the screen. Okay, let's see if I can do it correctly here. Okay, can you now see the screen?
Yes, it's clear, Dr.
Okay,
Nittaya.
wonderful, wonderful. Thank you so much. So I will take this like almost half an hour to talk about the key population-led health services model that we have explored in Thailand, and I also hope to learn from you as well. So let me start by using this HIV status neutral approach because I feel that this is something that like we used as a starting point in designing our service delivery model, and it can be very much applicable to other health conditions as well. So for us to use this HIV status neutral approach, it's the way that we kind of use it to redefine what is in our mind when we design service delivery model. And with the status neutral approach, it means that once people come in for HIV testing, you will be giving equal importance and urgency of services regardless of the HIV status. If they tested positive, then ART initiation will be offered on the same day in order to bring that person to the goal of you you to have zero risk of transmitting HIV to other people. But if they tested HIV negative, then a full set of combination HIV prevention will be offered to them so that they can make their own informed decision to choose their prevention choice in order to bring that person again immediately to the goal of having negligible risk of acquiring HIV. But just focusing around the disease is not enough, as we all know. So when we say people-centered approach or person-centered approach, it means that we design services around the people, but not the disease, but around the people. And that's when we will need to think of how best we can integrate the services for other health conditions into our service delivery model. And that's when we think about integrating sexually transmitted infections, hepatitis, viral hepatitis, and it's not only infectious diseases anymore, because we know that within the person, we will also need to address mental health, need to address harm reduction, need to address legal support, stigma discrimination support as well. And I put this slide on because it's something quite obvious, and it may be something that we also need kind of like innovative technologies to think about service delivery design, because we do know that with the 3 diseases that we mentioned at the global level, we are so much looking into how we can truly integrate services for a person thinking about HIV, thinking about STI, and thinking about viral hepatitis all together, because these 3 diseases share modes of transmission, share all those social and ecological determinants of health, as well as shared stigma and discrimination. And we do know that once we can integrate services, then we will perform, service delivery model will perform more effectively and cost less and increase clients engagement as well. And we talk about stigma discrimination here, and I believe that everyone realize that it's not just like stigma towards HIV anymore, but it's more of stigma that is targeting not only personal attributes, not only just the diseases, not just the viruses, but it's also all these intersectional stigma targeting socially unacceptable behaviors like substance use, like multiple sexual partner, and these all affect HIV, hepatitis, viral hepatitis, and STIs. And it's not only stigma towards the disease itself or towards the person itself themselves, but also stigma towards the services designed to address these diseases. And that's why I'm now going to just like briefly review the targets. Now we all know this UNS target, and our country, our government are focusing on these targets. So when we want to design service delivery, when we want to advocate for this service delivery to be integrated into a national system, we will have to link our services to these targets for advocacy purpose. And we do focus on the testing and treatment targets, right? The 95, 95, 95 targets. And even with only these testing and treatment targets, we're not doing very well at the regional level. We only have 62% of people with HIV who have viral suppression. That means that more than 1/3 of people with HIV in our region can still face like unnecessary morbidity, mortality, as well as transmission. And if we look at the prevention side of the service delivery, we will see here that it's only Thailand, Vietnam, Philippines who are doing better than the other countries, but it's not doing good, you know, because even with the countries with the higher number of people who have initiated PrEP so far, at the regional level, we only reach 3.5% of the 4 million PrEP target by the year 2022. I mean, against the target of 4 million people by the year 2025. So that's why when we talk about service delivery, we must not only focusing on 95, 95, 95 testing and treatment target anymore, because there are all many other targets that we should focus on. We must talk more and more about these targets, because it will help us in advocating for the service delivery model that is beyond the testing and treatment service delivery model. Because with these 695 targets, then you will be able to starting thinking more seriously about the 95 prevention target, 95 vertical transmission target, as well as the 10-10-10 targets, which is linked directly to what we are talking about here today, the 10% target for stigma discrimination, for punitive laws and policies, and also for gender inequality and violences. And there's also this 95 integration target as well. Sorry, 90% integration target here as well. That is what we have been talking so far today. And only when we talk about the 695 targets, we talk about the 10-10-10 targets, and we talk about the 90 integration target, that we will start to seriously think about people in these percentages, and not just the number in these percentages. I just put this slide to show you quickly that why we need to focusing on the 10-10-10 targets and to reduce the punitive laws, because in our region, Philippines and Thailand, you will see that we are very much similar in terms of having these punitive laws against sex work and against possession of small amount of drugs for personal use, and that certainly affect the service delivery access, as well as stigma and discrimination. We don't only talk about laws and policies that affect service delivery design, uptake, but also those affecting stigma and discrimination as well. And and since we are going to talk about community leadership here, we are going to talk about community-led health services, or key population-led health services. I think that's why we have to understand more and more about this 30, 80, 60 target, because here it's when like you can advocate for genuine and sincere like support from the government, from the policymakers, from your political colleagues, right? That sorry, we not only talk about community leadership as a pilot project, but we are talking about the institutionalization of community leadership into testing and treatment and prevention, because we are aiming towards getting 30% of testing and treatment services in our country to be led by the community, 80% of prevention target to be led by the community, and 60% of all these enabling environment programs to be led by the communities as well. So to bring you back to what we have done so far in Thailand is that we have had this community key population-led health services, or KPLHS, established since 2015. So it's almost 10 years now that we have been talking about these, starting by working together with the community and let the communities be the one who lead the design of the service and then co-deliver the services in order to make sure that we have a truly needs-based, demand-driven and client-centered services to be delivered or co-delivered by trained and qualified lay providers who are often members of our key populations. And we always use these three principles when we say key population-led health services, and these are demedicalization, simplification, and differentiation. And I feel that it's always fun when you think about demedicalization, how you can like do the task shifting or task sharing of certain roles, which are roles which usually happen in the hospitals, in the clinic setting, into the community. So we are moving away from facility-based service delivery to community-based and to community-led health services, and more recently into self-care service delivery, right? And then to think about simplification is also very fun, because we will be like thinking with the team on how we can find the less complex way to deliver care and to move away from the nice to have service flow into just the must have service flow, right? And lastly, to think about differentiation, because we all have this limited resources financially and also in terms of the number of people who are working in this field, that we will need to adapt the when, where, who, what building blocks of the DSD into moving us from the one-size-fits-all approach to a custom tailoring approach. And very quick on what the successes that we have seen so far through these community-led health services in terms of testing and treatment. We have successfully demonstrated that we can do same-day ART initiation using this community-led health service approach without the presence of nurse or doctors in our clinic, that we can start it ART within the same day among almost 95% of individuals who are diagnosed in community-led health services using teleconsultation with the doctors. And in terms of PrEP, we have seen that key population-led PrEP services have contributed to around 60% or up to 80% of PrEP services in our country so far. So we now have 70,000 people cumulatively who have started PrEP in Thailand. Right now, around 60% of them are receiving PrEP through these 14 community-led clinics in the country. And this is the standard key population-led PrEP services. When you have a clients coming in, lay providers be the one who do a blood collection and run rapid HIV testing. And then we shared the test results with the doctors via an online chat application. And then the doctors will review test results, review briefly the history, and then will do prescription of PrEP via that online chat application back to lab providers so that they can give out the first bottle of PrEP or the 3 months, 6 months bottles of PrEP for PrEP follow-up to the clients. So this all happens within almost like an hour of clients coming in to the clinics. But even with this like key population-led PrEP services, we have seen that we have not like reached even like 30% of people who would benefit from PrEP in our country. And that's why we need to think about like more innovation of how we can deliver PrEP to more people in our country. Beginning this year, we started the mobile key population-led PrEP services, and using the same flow that will happen in the clinic, but now moving out to the people. And we have seen so far the variations of PrEP uptake. You will see a PrEP uptake of 3 to 10% in Chiang Rai and Chiang Mai, which is in the north of the country. But in Bangkok, with the Rainbow Sky Association of Thailand, the RSAT team, we have seen around 20% of PrEP uptake using this mobile KP-led PrEP service flow. And then for HIV self-testing, because in Thailand we have integrated HIV self-testing into our universal health coverage starting this fiscal year, and in active services starting early this year. We still the same thing, using the same KP-led PrEP service flow, but to replace HIV self-testing, to replace rapid HIV testing with HIV self-testing. And here we also bundle STI self-sampling into the service delivery model, because we know that people may not come to our in-clinic service, so they may miss the STI services access. And the best that we can do right now, that we still don't have don't have self-testing for viral hepatitis, don't have self-testing for the other STI like syphilis or gonorrhea chlamydia, is to ask people to collect their own samples and then send the samples to our laboratory so that we can send the test results back to them by this online chat application, and then ask them to access a treatment as needed through local pharmacies. And with adding HIV self-testing here, we used it for both PrEP initiation and PrEP continuation. And we only now focusing on using blood-based HIV self-testing to generate the data and to change the guidelines in the country. So you will see here that with using HIV self-testing, we have seen so far that 40% of those who tested non-reactive and those who are willing to share their HIV non-reactive test results with us, we see that 40% were linked to PrEP services. And among these 40%, the majority are those who initiate PrEP for the first time, while the other 1/3 are those who use HIV self-testing for PrEP follow-up, and around 14% were those who restart PrEP after they have discontinued PrEP in the past. And what is interesting is that if you look at this PrEP uptake by populations, you will see that you have like the highest proportion of people who were linked from HIV self-testing into PrEP among those who are MSM. 60% of them did so, compared to 27% of trans women or cisgender women. But if you look at the proportion of those who were linked to PrEP, you will see that the majority of trans women and cis women, 81% here and 56% here, were those who started PrEP for the first time. So if you are trying to enhance the uptake of PrEP among certain populations, like for example in Thailand for trans and cisgender women, you may want to use HIV self-testing to reach into like the new markets of PrEP initiation. But for MSM, they are mainly use HIV self-testing for PrEP follow-up or PrEP restart. And just moving away from HIV, because I've been talking about integration of STI services, we can also use key population-led health clinics to also deliver STI using the point-of-care platform, right? And this is mainly to enhance the concept of test and treat for any infectious diseases. And by having the point of care machine within the clinic, in which like many of your clinics also are doing this, we can shorten the timing from testing to treatment. One limitation for this key population-led health service in Thailand is that we don't have doctors or nurses in the clinic, and that's why we still cannot provide treatment which needs injection of the medication. And so for syphilis or for gonorrhea, which needs injecting treatment, we will still need to refer people out for the treatment. But at least we can shorten down the timing from diagnosis to treatment from more than 2 or 3 months at the beginning to now within around a week or so. And to move to hepatitis C, we have seen kind of the explosive HCV epidemic among MSM and trans women in Thailand. And you can see from the graph on the left side here that right now the incidence of hepatitis C has been increasing to almost like 5% per year among MSM. And this is the number from HIV positive MSM. And that's when we started to integrate hepatitis C rapid test into our key population-led health service model. And what we have seen so far is that, yes, we can use this test for serology, but at the same time, if we cannot do HCV RNA confirmation, we will lose like more than half of people who tested positive by anti-HCV, who will not reaching the step of having HCV RNA confirmation, as you can see here. And that's when we started this implementation research using key population-led same-day HCV test and treat model, in which we do HCV RNA within key population-led clinics, and still using the same model. We don't have doctors or nurses, so we use telemedicine with the physician, so that if a person coming in tested anti-HCV positive and on the same day have HCV RNA confirmed to have active HCV infection, then the doctors will do telemedicine and prescribe BAA for that individual. So we can increase the proportion of those who tested anti-HCV positive and then receive HCV RNA to 100% compared to less than half of those if we don't do HCV RNA confirmation within the clinic. And we have seen so far that among those who tested HCV RNA positive, then 76% can start DAA within the key population-led clinics, and the remaining does not meet the eligibility criteria, and we need to refer them to specialists outside of the key population-led clinics. And we have been talking about STI, HIV, viral hepatitis, no, and I think we cannot getting away from knowing that we are seeing this like increasing HIV, STI, and viral hepatitis among our key populations who are engaging in sexualized substance use, or in Thailand we call it chemsex or high fun, right? That's when we started to think more seriously about like proposing this service package to our National Health Security Office to be considered that we need a comprehensive harm reduction services for our key populations who are engaging in this sexualized substance use, so that we have a standard service delivery package that can be included under universal health coverage, and that our key population clinics can then reimburse service costs to their clinics. And this comprehensive harm reduction service package came from a series of consultation with community members, so that we ensure that when we talk about harm reduction services, it's not only HIV testing or needles and syringes, or just PrEP and then you say that you are already doing harm reduction services. Because if you want to design service delivery around the people, then you know that it's not only enough if you talk about sexual health as part of harm reduction service, just a part of harm reduction service, but you also need to deliver mental health services. You also need to deliver social and legal supports as well. And you need to know more and more, much more about substance use specific harm reduction services that will include like drug use literacy and skills, and will include all those syringe, needles, and overdose management as well. So right now we are doing this implementation research on various service delivery models that we can deliver that comprehensive harm reduction services. And we have 3 models so far. The first model is to build upon our KP-led clinics who are very specialized in now delivering sexual health services, right? But we need to empower ourselves to be more capable of also delivering chemsex specific harm reduction services so for us to understand more about substances that are commonly used among our key populations who are engaging in this sexualized substance use, to be more capable of delivering mental health screening and primary management of mental health conditions, as well as to be more standardized about how we deliver legal and social harm reduction services. And that's the model that we are now piloting at the Rainbow Sky Association of Thailand. But at the same time, we are engaging more and more community partners who are doing these legal and rights services. So that's their expertise, but to empower them to be able to also deliver substance use service, to deliver mental health service, and also to deliver sexual health services. Now that we have HIV self-testing available under universal health coverage in our country, and we also are more familiar with using tele health to support the other civil society organizations who may not be very familiar with providing sexual health service or mental health service in a full scheme, as are already happening in the KP-led clinics who are specialized in providing sexual health clinics. So here we have the Foundation for Action on Inclusion Rights of FAIR being our partner in piloting this model, which is the legal and rights focused harm reduction model. And lastly, the third model is to make it to be on the spot model, because we know that in several venues in Bangkok, especially in sauna, we will have like almost like 100 or few hundred people engaging in sexualized substance use every day in that venue. And this is how we empower staff within this sauna venue to be able to provide basic sexual health, mental health, and legal harm reduction, as well as chemsex-specific harm reduction services within the model. So we have one sauna in Ram Khamhaeng area, which is one hotspot area in Bangkok, who will pilot this model. And we are now, at the same time, also working with our National Health Security Office to propose our community-led comprehensive harm reduction service package for them to consider if this can be included under our universal health coverage as well. And I will now go to the last part of the talk here, talking about the transgender-led service delivery model using the Tangerine Clinic as the example. And we have the Tangerine Clinic as an trans-led integrated gender-affirming sexual health services, providing the services, hormone services, sexual health services, and well-being services, led by a team of transgender staff. And what we have seen so far is a very high uptake and also like visibility of trans people in the country who need the services. So far, we have right now almost 7,000 or so trans clients in our clinic. And we have seen quite a good proportion of people who tested HIV negative and then receive PEP and PrEP services, as well as high proportion of those who tested positive and receive ART initiation. And we also made sure that we have the service designed to enhance equity in service access among trans population. And the example here is the number that we have seen so far for transgender women, that we reach those who are non-Thai as well, those who are using substances, those who are engaged in sex works as well. And to talk about integration, we started Tangerine Clinic with only the integration of gender affirming and sexual health clinics. But then we added later on mental health services as well. And here you will see that if you start to screen people, then you will see that there are these mental health conditions that you will also need to prepare your clinic to be able to deliver primary management or linkage to management for mental health. And here we have seen that we have certain proportion of people who will be screened positive with moderate or severe depression symptoms that will need the referral for our psychiatrist colleagues, or to have primary management for those who have mild symptoms. And the Tangerine Clinic also recently planned to integrate sexualized substance use for trans and gender non-binary people, because we have seen so far that we have substantial proportion of clients who are engaging not only in substance use, but also in sexualized substance use as well. And we have been progressing quite okay so far in using this community-led research and community-led data to propose that we need competent health services to be part of the universal health coverage in our country. And so we have been moving quite okay so far, from submitting the petition in 2020 to now. We have NHSO committed to allocate $4 million to support gender affirming care in our coming fiscal year. So to conclude, I think we have learned so far that the key population-led or community-led health services will allow us to design the integrated services around the people and not just around the disease, and to move from health equality to health equity by the power of the community. And always the three principles, demedicalization, simplification, differentiation, will allow the translation of innovations of science into the actual implementation. And that we need community leadership, not only in service delivery design, but we need community leadership in advocating, in enabling environment, so that we can make sure that we will sustain these equitable health responses. And always think about community-led research when we design service delivery, because we always need data to drive policy advocacy. And lastly is the integration that is not just around the infectious diseases, but also for the other health conditions like mental health, harm reduction, and also social and legal services as well. So I will end here because I think I have use more time than I'm allowed here, and to acknowledge all our partners here, and to end by this slide that we must aim for health equity, and with the power of the community, we can certainly do that. Thank you very much.